Informed consent. Before initiating a trial of opioid analgesic therapy, obtained informed consent. A continuing discussion with the patient regarding chronic opioid therapy should include the goals, expectation, risk, and alternatives. Patients must make lifestyle changes to accommodate their chronic pain. You've got to try other things such as physical therapy, relaxation training, or behavioral health treatment if you can find that available. Repeated failure on the patient to follow through with these raises questions about the motivation of the patient and the appropriateness of continued opioid therapy. You want to have a written chronic opioid therapy management plan with your patient. This is the patient-provider agreement. It used to be called a contract. We've gone through that. Now we call it an agreement, where we want you and the patient to both know what is expected of both of you. Okay, you're going to talk about the side effects of the medication, constipation, nausea, sedation. The nausea and sedation typically get better after just a few days, as well as other serious side effects that these patients can abuse this medicine. They can become dependent or addicted to it. They can overdose and it can kill them. Okay. You also want to tell them that they can develop hyperalgesia from taking this medication. The medication can actually make the pain be perceived as worse. They can have endocrinological or sexual side effects and sexual dysfunction from taking this medicine. You ought to make sure the patients know that. I mean, when you, it's kind of disheartening to some of the guys that we see now that he was talking about yesterday that have been on opioids for a while, and they can't understand why all of a sudden they're not shaving like they used to, and you check their testosterone level and it is significantly decreased because of the chronic, ostensibly because of the chronic opioid therapy. Chronic opioid therapy management includes goals of therapy. You got to tell them they got to take it as written, and they have to have expectations for clinic follow-up. They can't come early. If they come late, that's okay. They just don't get an increased amount of medication. That you may drug test them, that you may bring them in for pill counts, that you're going to check their PDMP to make sure they're not getting medications anywhere else. You have an agreement with the patient. Follow the agreement, both for you and for the patient. That on a scale of 1 to 10, chronic opioid therapy doesn't take your pain from 10 to 0. It improves it a few points, 2 to 3 to 4 points. But if they're looking for pain relief, total pain relief, cure up their pain, they're looking for love in all the wrong places. They're not going to get that from opioids. It may be that way for a few days when you first titrate, when you first start, they may be, quote, pain-free, but they're not going to be there for long. The medication just doesn't last that way. The patient-prescriber agreement is a document signed by both the patient and the prescriber at the time an opioid is prescribed. It clarifies the treatment plan and goals, and hopefully you'll have other family members there so that they can understand that. You want to assist in the patient education. Okay? For patients at higher risk of misuse, use of clear written guidelines are particularly helpful to reinforce, and if you've got family there, to make sure that the family understands what you're doing. And because if you've got family there, you can leverage the family to help you hold the patient responsible. Consider a patient-prescriber agreement. I encourage you not to just consider it, but to always have one. The board expects you to have one when you see these patients. When you end up in Montgomery because of some allegation or something, and you do not have agreements with these patients, it is not looked on favorably. Make sure that they get all of their medications from a single prescriber. As we mentioned, we want you to use the PDMP, and that is the reason why it will be required for you to be registered with the Alabama Department of Public Health prescription drug monitoring program if you are going to renew your Alabama Controlled Substance Certificate or qualified Alabama Controlled Substance Certificate. You need to get registered. And so we've got roughly 5 weeks to the end of the year, 5 or 6 weeks. So that needs to be something that you put on your to-do list for Thanksgiving week if you are not registered. Tell them to safeguard their opioids. Remember, tell them that they need to treat every tablet or patch or whatever as if it's a $100 bill. They don't leave $100 bills laying out on a cabinet so somebody that stops by their house could get them. So they don't need to put these where they can get them. Keep them locked. Use a medication safe. He showed one yesterday that they can fill at the pharmacy, but there's others that, you know, just a little key, or I've got one that has a fingerprint reader, and it actually works. Don't share or sell your medication. That is a violation of the law. Instructions on what to do with the medications when no longer needed. You know, there are things where you can mix it with cat litter. For fentanyl patches, you fold them over, you put them in the toilet and flush them. But you don't just put them in the regular trash. Commitments to return for follow-up visits. Comply with appropriate monitoring. You may do random urinary drug testing, pill counts. You're not going to increase the frequency of their prescriptions. As we mentioned yesterday, Medicaid is now wanting you to, if you're seeing the patients on multiples of 28 days, write them medications for that amount of the medication rather than writing 30 days, because if you write 30 days and then it's a 28-day month, they sort of have a little benefit there. And talk about the things that may lead to opioid discontinuation, and have an exit strategy. If you can't fly the plane, don't take over. If you can't land, don't take off. If you can't say no, don't say yes. You know, don't be afraid to just say, no, I can't get into this. Now, that being said, I don't want you to go back to your office and say, it's just too much trouble to write pain medicine, I'm not going to do it anymore. Because what that does, that puts a disproportionate load of taking care of patients with pain on those patients, on those physicians and nurse practitioners and PAs who are treating pain. So we need to try to all do our appropriate part. If you see that people are coming from miles and miles away to come see you, you may want to reconsider, you know, do I have a reputation of being somebody who writes too much pain medication? And be honest, you know, be honest when you look yourself in the mirror. You look into your own soul, are you doing the right thing? You need to monitor your patients during their therapy. Clinicians should always reassess, trust but verify, but reassess these patients. Regular monitoring of patients once opioid therapy is initiated is critical because therapeutic risk and benefits do not remain static. And the patient may, as they get better, may not be taking quite as much as they were. They may be doing a self-reduction, but they are hoarding medications at home in case my back ever flares up. If you've ever had a back injury, you know that the first day is just really bad. And then if you were to get some medication, some narcotics for that, you know, patients who have had these recurrently, they hoard the medications at home because they don't want to run out. They want to have some in case their back flares up on them again, in case they bend over and it hurts again, or as they tell me, their back goes out. I don't know where their back goes out to, but apparently when it goes out, it hurts. But y'all reassess the patients. Make sure that they're not getting worse in front of you and you're not doing anything. Monitor the patients during this therapy. Make sure that they have monitoring of their pain intensity. Ask them how their pain is doing every time they come in. Where is the pain? What's the pain doing? What's it doing to you? You know, as they showed yesterday, Dr. Doles and Dr. Herrick showed the pain pictures where they draw on it. That's getting harder and harder to document in the electronic medical record, but you got to have some way of showing where they're hurting. What is their quality of life. Is their health-related quality of life, is it better on the medicine or is it worse on the narcotics? You know, you can give them medication and make their situation worse. Are they having side effects that are a problem? Are they chronically constipated and you haven't adjusted for that? Are they somnolent? You know, you see people that are going to the methadone clinic and they live their whole life in a daze because they hardly ever wake up. You know, and when they wake up, you know, and they talk to you, you can tell they're in a drugged state. Now, are you putting people in a drugged state like that by these long-acting, extended-release opioids that you're ostensibly using to treat their pain? Are we overshooting that and we making them zombies, if you will? Are these high-risk patients? As Dr. Smith said, when you do this SOAP study, SOAP questionnaire on, is the patient at risk for bad behavior? If they are, you have a responsibility, an inherent responsibility, of making sure that you're not making these patients' lives worse. Although progressively higher doses of opioids may be beneficial, and 15 years ago, they said there was no upper limit. You know, as Dr. Dole said yesterday, the upper limit effective dose hasn't been shown to be much benefit above about 180 milligrams of morphine a day. And that's still a pretty heroic dose. But, you know, we all have probably seen, and certainly we on the board have seen people who are prescribed much in excess of that. And just realize that there may not be any incremental benefit to these higher doses of medication. Theoretically, opiates have no maximum or ceiling dose, but there's little evidence that these heroic doses are additionally beneficial to the patient. Opioid treatment may require restructuring of your patient-physician relationship, including tapering or discontinuing of the opioid therapy if they're getting medication from other places, if they're abusing the medication, using the medication in ways that you have not agreed to with the patient. You have to anticipate and treat the common adverse events. As we mentioned, the constipation. He who writes the narcotic takes care of the bowel movement. Nausea and vomiting, that typically goes away, but if they're having it very bad when you first start, you can use a different approach. You can use rectal morphine for people who have severe pain. That's a way that you can give it to them, and it's hard to throw that up. Drowsiness and sedation tend to wane over time. That's not a side effect that is going to stay with you. That is a sedating side effect, and those typically decrease in relative short order. Pruritus and myoclonus, those are the itching they get from morphine. The guy in the comedy this morning, or they were talking about, somebody was talking about itches a lot. Well, that's a side effect that goes away typically. The one that hangs with you, the two that hang with you is the eyes, the pinpoint eyes, and the constipation. The stimulative effects of those doesn't seem to go away. Monitor adherence and aberrant behavior in these people. It's important to monitor them, drug screen, make sure they're doing what we agreed to in the treatment plan, make sure that they're getting better, that they're more functional, that their pain is controlled, that they're able to have the best quality of life that they can from a reasonable, prudent amount of this medication. Recheck the PDMP on these people. If you're giving them long-acting narcotics, it doesn't have to be every time. It would be great if you checked it every time, and now that you can delegate to people to help you do it, there's less reason for you not to check it every time they come in. Get a urine drug screen to make sure that they're taking what they're supposed to be taking. As I mentioned in an earlier talk, there's sometimes that people will alter their urine to make it look like they're taking their medication superficially, but they're really not taking the medication. Talk to the family members or caregivers, and this is important. You know, when you're treating both pain patients and patients that have substance abuse problems. Talk to their family members. Know what's going on with them. Use the monitoring tools like Dr. Smith went over in the first section. Do a medication reconciliation. Call them in at unexpected times and do pill counts. That is a really effective method of ensuring quality, okay, of your relationship with your patient. And you put that in your prescriber-patient agreement, that you're going to call them for pill counts. And when you call them for pill counts, they need to come in. You know, you don't call them at 4 o'clock and say, you got to be here by 5, typically. But, you know, you don't say, hey, look, we want to do a pill count next Thursday. Okay? The shorter the interval between when you call them and they have to come in, the better the quality of the pill count is. The current opioid misuse measure, the COMM, is a good tool to use to try to question the patients and get back at them. But you can also say, have you ever had to take more than you were prescribed? You know, and ask some questions like that. Have you ever hurt so bad that you had to take more than you were prescribed to tolerate the day? Address the aberrant drug-related behavior. Don't just sweep it under the table. Don't be afraid to have to confront these patients. Don't have a confrontational phobia. Behaviors that are less indicative of aberrancy is, as we mentioned before, if they have to every now and then take a tablet or 2 extra, like we was talking about the colon cancer patient who got a gastroenteritis, who was hurting really bad, who took an extra dose or 2. You know, that's aberrant behavior. You talk about it, you keep it under control. If they use the medication occasionally to treat something else, if this cancer patient with colon cancer fell and had hip pain that wasn't a fracture, if she took an extra tablet to do that on 1 occasion or 2 occasions, that's okay. Use your common sense. But now if they say, look, I'm having pain all over and 2 a day just wasn't enough, so I started taking 3 and I like that so good I'm having to take 4 a day now. Now that's the type of logic that they use that is not logical. And that's where you move them from the left side of the screen to the right, that are more indicative of aberrant behavior. That would be multiple dose escalations or non-compliance, despite warning them not to do it. If they forge your prescription, that's a violation of the law. If they're getting medication from other sources, legal or illegal, that's still, you know, violating your agreement with them, and you cannot tolerate that. If people are diverting, you must stop giving it to them. You have to be suspicious, prudently suspicious, of patients diverting medication. You know, I miss people that are diverting. I guarantee you, you've missed people that are diverting their medication. And I'm not talking about giving one to a family member because they got a headache. I'm talking about they're selling them, giving them away, swapping them for favors, and doing things like that. Other things that you have to address. If people come in and you do a urine drug screen, they got cocaine or methamphetamine. You know, in today's society, I really don't want them using marijuana, and I seriously counsel one, but I don't always fire the patient that's using marijuana. We have a prayer meeting about it. We talk about it. We address it, and we're going to address it again. But if they come in and they're using cocaine and methamphetamine, if they got methadone in their system, and I'm not giving them that, if they've got other narcotics in their system, if I'm not giving them benzodiazepines and they got benzos in them, and if they've got soma in them, we're going to have a real talk, because there's no reason for them to take soma other than to get a buzz. So you know, you've got to stratify their behavior with your response, and you can't be afraid of having that response. If they do it, you've got to have a response that you have already predetermined, and you've got to address it with them and do what you say you're going to do. Use the PDMP. Alabama's, it's going to show you a picture here in just a second of a report from another state. Alabama's is a well thought out report. It works very good. Compared to when it first came online in 2007, it is much quicker. I can do a query on somebody in typically less than a minute, and I'm looking at it. As Dr. Smith was saying, while the patient's out of the room, you access the PDMP. I have a computer in the room, and I access it right there, and I look at him and I say, what's the deal here? You're going to see these 3 other doctors, and you coming to me wanting pain medicine? You know, something's got to change, and it's going to change right now. Either I'm not going to give you any, you're going to get it from them, or you're through with them, and we need to call them and tell them that you're not going to be getting pain medicine or whatever medicine from them in the future. And then they'll, most of the time, oh, that's a mistake. And it could be. And you tell them, okay, well, if it is, we'll know. But you admit that you've been to that doctor. Well, yeah, but that was my brother that got that medicine. No. And so you go on and get the information that you need, contact the pharmacy that put it in, contact the physician that ostensibly wrote the medication. You will find that despite the patient saying there are mistakes in there, that it's not that prone to mistakes. There's a big push to get it real time or every day. You know, it's a problem that it's a few days behind, you know. But if I'm seeing the patients every month or 6 weeks or 2 months, you know, if they've got medicine yesterday or the past 3 days from somebody else, I may miss that today, but I'm not going to miss it when they come in next month. And so it's much better that it's, you know, a few days late and accurate and has all of these other features, like you can look in to see how much you're writing and how much the mid-levels, the PAs and nurse practitioners that are affiliated with you are writing in the future, because that we should be doing that to make sure. But it's much more important to me to have that functionality rather than it being real time or essentially real time. But access it. Don't put that in the back of your mind. We occasionally see physicians in Montgomery and say, are you registered with the PDMP? Yes. Well, the investigators have already gone into your PDMP account, and they can tell how many times you have accessed it. You know, we have people that come down that are writing heroic amounts of medications, and over the past 6 months, they've accessed the PDMP 3 times. You know, I do it 3 times before lunch on days when I'm leaving early. And so it doesn't take that much time. Learn how to do it. You can put a shortcut on your Windows desktop that takes you to the site. Then you just have to put in your password. With the web portal now, the ADPH web portal, you can make it so you can get back in very quickly. You don't have to have that attestation screen that you click on every time. It's a lot quicker to get in there. And while we're at that, the web portal also will permit you to do death certificates on that same web portal. And that electronic death registration for people that do more than 10 death certificates in a year, that will be coming in the future. So use that same access for the PDMP to do that. Okay. This is the status of state PDMPs. Missouri is the only one that has no legislation thus far to create one. Alabama's was created, I think the legislation was passed in 2004, started collecting data in 2007. We were able to access it in started collecting data in 2006. We were able to access it in 2007. So we now have several years history, and it's not archived. So you can put in the specific date range that you want. The default is 6 months. However, I typically want to see, for a new patient, I want to see a little bit more than 6 months, so I'll go back. I just changed the last number of the year from 6 months ago is now 13. I'll change it to 1 or 2 to go back to 2011, 2012. And that gives me a longer history. If it's somebody I'm really having problems, then I go back and do it again. I go back to 2006 to see what's been going on. And it's pretty amazing to see people who have been using and abusing drugs with many different doctors now for 7 years. The substances monitored, you notice that Pennsylvania only does Schedule 2s. We do 2 through 5s. There are other states that do 2 through 4s. They don't mess with 5s. But Alabama monitors all controlled substances 2 through 5, including Soma, because we were the first state to control Soma. And so we started monitoring that quite some time ago. These are the states providing access to prescribers. Note, Missouri doesn't provide the access because they don't have one at all. But Wisconsin, Nebraska, and Pennsylvania, the prescribers can't look at it themselves. So it's sort of, I don't see the reason for it there, but that's what they did. Okay, the requirements for prescribers to register, you can see that Utah, Arizona, New Mexico requires the prescribers to register with the database. There's no requirements in these other states except Alabama. You're going to now have a requirement, so our color will change. If you're going to have an ACSC, you will be required to register with the PDMP. Requirements for physicians to access the data bank. There is not a requirement in Alabama for you to access it. It does provide you with a layer of safety if you were to get called to Montgomery. Now, this is not discoverable in civil proceedings. That means that if you were to have a malpractice suit against you, they cannot access the data bank to see if you accessed it. For civil cases, it is not discoverable. That doesn't mean that you can't mess up. If you print this out and put it in your patient's chart, and then somebody sends a request for a copy of your chart, and it's in there, you have now broken the privilege. You've also violated the law because you're not supposed to disclose that. So, what's the moral of that story? Don't print it out. You can write in the chart things that you find from it. You said, check the PDMP, patient seeing multiple doctors. They can't do a thing about that. That doesn't break your privilege. But if you print it out and put it in there, particularly if you send it to somebody else, you have broken the privilege and you have violated the law. So the moral of the story is don't print the thing out. There's no benefit to it. Look at it on the computer screen. It's the same information. It just, if it's not printed, it's hard for them to take that image in their eyes if you show it to them. So no, you see here, you saw Dr. Jones right there. You know, they can't take that with them. The benefits, I don't want to have hyperbole about this, but they are tremendous. They protect you. They help you take care of these patients. Some are available 24/7. Ours has been available virtually nonstop since 2007. You know, of course, the day that I really have a new patient in that I'm suspicious of, that's the day that it will go down. And you get so frustrated on those days. When that happens, of course, you need it 5 times that morning and it's not working. Get the phone number and call them. Call Miss Bishop or Donna Jordan at Montgomery, get their phone number and call them and tell them that it's down. Or call HID over in Auburn, which is the company that operates the database. Tell them that it's down. Sometimes we know that it's down before they do, because they're seeing the server bank, and then we see that it's locked up. And you know, early on I was guilty of locking it up because Joe Smith would come in, and I would put in Joe Smith and then put in instead of putting in his exact date of birth, I would put plus or minus 2 years. Wouldn't put in an address, so it pulled up all the Joe Smiths that were born within 4 years, and so they didn't have enough capacity, so I locked it up myself a couple of times. But you don't have to put in all that. They do now have where you can put in their driver's license number. There's a field there, and once you put that in, you put in their last name and part of their first name, it'll pull it up pretty quick for you. But if you just put in their last name, the part of their first name, their date of birth, it'll pull it up. And so it's gotten a lot better. So use it, use it, use it. This is the way it looks from, I think this was Nebraska or somewhere. Ours is much easier to use. You can sort ours by prescriber or prescriber by date or by date. I like to see it sequential date-wise, and I can pick out if they got different prescribers, and you can too as you look at it. But you'll develop your own personal way that you like to look at it, and I encourage you to become very familiar with using it. Use it more than you think. As I mentioned yesterday, the VA is going to start putting their medications in. I'm not sure about the active duty armed services hospital like Fox Hospital and Huntsville or Columbus over in Mississippi. But CVS Caremark, the big mail order pharmacies, they're putting it in there, and I mean it's in there just like the CVS down the street. Okay, this looks a little bit more like Alabama's, but it's still, I don't think, quite as user friendly. It does show the number, and see there on second line they got 270 oxycodone, 270, 240. It's amazing when you start seeing these people that are getting 600 methadone a month, 840 methadone a month. You know, you realize that somebody's just gotten off the plantation, and so you know we want to get them back in the right way, because it's very little indication that that's doing any good for the patient, and then when you start checking that, you know, the patients are doing badly. Unsolicited patient threshold reports. As you mentioned yesterday, 6 and 6, 6 prescribers, 6 prescriptions. We'll get a letter. They manually generate those letters. In the coming year, with the increased capability of the system, we may go to 5 and 5. But if you get one of those letters, that means that you haven't been checking enough, and you got 5 other of your best friends that aren't checking enough either, and you got a patient that's lying to all of you. So you want to find the doctor shoppers. We now have a law that, you know, when they're doing that, they're playing with fire. They can get a Class A misdemeanor, or if they graduate from Class A misdemeanor, they can graduate to a Class C felony, and that's time in prison. Rationale for urine drug testing, we've talked about it. In certain cases, in certain patients, certain situations, every time they come in my front door, I'm going to drug test them. Otherwise, for patients that, say somebody's got they've had half a dozen back surgeries, you know, they're on a walking stick, they're on a walker, they're 45 years old, they're, you know, can't work, and, you know, I may not drug test them every time they come in, you know, if I believe them, you know. But there again, those are the ones that can be lying to you. So you need to drug test them periodically to keep yourself comfortable, to keep yourself honest, as well as to keep the patient honest. You want to provide the best care for them that you can, but you don't want to get you don't want to get hosed down yourself. Interpretation of urine drug test results is challenging. The point of care immunoassay tests that you do in your office are fraught with errors, but they give you a way to talk to patients. If I have one that shows up positive for cocaine, what do? I go back in and I said, you know, I got a problem. Your point of care, your dipstick, shows that you're taking cocaine. Do you need to tell me anything? And then I tell them that, look, this one today may have an error, but I'm sending it off for confirmation. You've already signed for it, because we make them sign for the confirmation when we do that. So we're going to send it off. If you need to tell me anything, this is your opportunity. This is your get out of jail free card. If you tell me the truth right now, oh no, I have never done cocaine. When the comes back from GCMS, from the confirmation lab, if they don't have cocaine in them, then they have reinforced my relationship with them. I had a false positive. But if it comes back and they have, oh no, I've never done cocaine, and it comes back, and not only does it show cocaine, but it shows soma. And when they were supposed to have benzos in there, and I'm giving them Ativan, and it shows Klonopin and Xanax, we got a problem, okay? Because they had an opportunity. I gave them an opportunity to come clean with me, and they didn't take that opportunity. So they have lost that opportunity. You never get a second chance to make a first impression. And so when they come back in and they have not told me the truth, then that changes our relationship. So evaluation of urine drug screens has a little bit of a challenge to it. When you send them out for confirmation and you get them back, and you get back not only the parent compound, but the metabolic products of it. If you see somebody that has, let's use buprenorphine. If you see somebody that's got the native product of buprenorphine but no metabolic products, they're putting some in the urine because they can't put small enough, whereas normally their native product, if they were using the medication appropriately, would be 30 to 100. Theirs is 5 to 7,000. They can't break off a small enough piece. So they lied to me. But if they come in and there's no parent compound, but there's metabolic products, and he says, Doc, I ran out 2 days ago, but I hadn't taken anything else. And when you drug screen him in your office, it shows negative. You talk to him. Say, what happened? He said, I ran out 2 days ago, and I hurt my back, and I took an extra one. I'm sorry, but I hadn't taken anything else. You get their urine drug screen back. The dipstick in your office, as I mentioned, is negative. But it comes back in their metabolic products. Their norbuprenorphine shows it's at a level of 100, but their parent compound is negative. That reinforces your relationship with that patient. They're being honest with you, and they have told you the truth. That makes you, in the future, want to give this patient a little bit more leeway, okay? Not too much, but they get benefit of the doubt because they've been totally honest with you in a situation that did not appear to be honest in the first place. Main types of urinary drug testing is, everything's got a cutoff. As we mentioned before, the answer to pollution is dilution. If they drink a lot of fluid, they may get under that threshold, but over the years, the limits of detection have gone down, so the threshold is down lower. They may be subject to cross-reactivity. They're lab-based or point of care, as I mentioned. I do point of care in my office, but it is subject to false positive and false negative. It doesn't test for everything that I need tested for, so I send out labs every day. You got to make sure that you ask for the right test to be done. You want to check for the appropriate medications. If you're just doing a 9 to 5 dip in your office and somebody's on oxycodone or hydrocodone, it probably will not show. Klonopin is difficult to detect in a point of care benzodiazepine. So remember that. Specifically confirm the medications that you are really looking for. Detecting opioids by urinary drug testing. Opiates is a wide thing. You've got to be specific. When you send them to your reference lab, they will break that down for you. Ask them to break it down to the ones that are currently being used by you or the ones that are currently being used by the patients in your practice. Confirm the presence of these medications. You can't make all your decisions based on a point of care test. The specific windows of drug detection. We all know that if you use a lot of marijuana and you're overweight, the marijuana may stay in your system for a month. But if you have a thin, small person who says they smoked marijuana last week and it's not positive in your point of care today, it may not be positive anywhere because they may not have any fat stores for the marijuana derivatives to be stored in. Cocaine is rapidly metabolized. If they're positive for cocaine, they say, I used it 3 weeks ago. They may have used it 3 weeks ago, but they probably used it 3 days ago too. So don't let them get away with that. Know the windows of detection for these medications. Most drugs is 1 to 3 days. The long actings, The pharmacology, once it's dissolved, the pharmacology of it being in your body is exactly the same as a short-acting medication. The amphetamines, less than 3 days. Marijuana, chronic use up to 30 days, as we just mentioned. Cocaine is the benzoyl ecogenine, is the metabolite that they measure. It doesn't come from anywhere else. It only stays for 2 to 4 days. So if they tell you they took it, they used cocaine a month or two ago, they're lying. Methadone can stay for several days, particularly if they've been going to the methadone clinic or they've been using high dose of methadone for a long period of time. It can hang around with you. Benzodiazepines, similarly, if they've been using high doses for a long time, can hang around for a while. Okay, when you get the urine, make sure that it's got the right temperature. A urine of 70 degrees is that you measure the temperature off within 4 minutes of the time that they void. If it's 70 degrees, this person may be dead. Patient temperature equal to room temperature in a cool room is not a good prognostic sign. And so if they have urine that comes out and it's that temperature, they have, excuse me for saying it, they've peed on you. The pH fluctuates in humans. It can be 4.5 up to about 8, 8.25, something like that. Creatinine varies with hydration, but there has to be creatinine in it for it to be human urine. A normal urine is greater than 20 micrograms per milliliter. It can be diluted down to less than 1.003. Positive results, we have spoken about this. It demonstrates recent use of the drug. As mentioned, they only stay in your system for 1 to 3 days. Positive results don't provide enough information to determine the exposure time, the dose, or the frequency. You just know that it's there. You don't know how much they're using. If you do quantitative testing and you see that somebody's got a heroic amount in their urine, they didn't take 1 tablet. They didn't take 1 hit. So you can make some inference based on the quantitative urine results. Interpretation, the testing technologies are improving. They're going to evolve. And part of this is because the people that try to subrogate, mislead you, falsify them, they're evolving and they're doing things that they weren't doing previously. Differences exist between the immune assay test and the immune panels. I was telling somebody yesterday about we have a 12-panel point of care in our office that we use that tests for methadone, morphine, opiates. It have a new one that tests for soma in the office. I'm not using it yet, but they test for cocaine, marijuana. You can get you one that tests for multiple different drugs, including now buprenorphine in your office. So you tell them what you want. When you go up on the number of drugs tested, they cost incrementally a little bit more, but not as much as you would think. This just shows the metabolic pathways. If they're using codeine, it can show up as hydrocodone, as hydromorphone. Morphine can show up as that. If they're using hydromorphone if they're using morphine and they were to have a positive drug test for hydromorphone, that would be a metabolic product of morphine. Do you catch my drift? Interpretation, investigate unexpected results. Discuss with the lab if you need to. Discuss with the patient because you need to. Chart the results, the interpretation, and the action. Don't ignore unexpected results. That may get you and the patient in real big trouble. You may need to refer the patient to a substance abuse counselor, a substance abuse professional. You can look online. There's a group called SAMHSA, S-A-M-H-S-A, that will help you find a treatment facility, substance abuse treatment facility, and mental health treatment. Be familiar with those referral sources, because when you're treating with extended release and long-acting opioids, you will inevitably and undoubtedly need to be able to refer somebody. Thank y'all.
I'm Dr. Steve Furr. I'm a family physician in Jackson, Alabama. I've been the past president of the Medical Association of the State of Alabama and used to serve on the board of medical examiners. This next session of the REMS course is about counseling patients and caregivers about the safe use of extended release and long-acting opioid analgesics. Voltaire, the great philosopher, said this: common sense is not so common. A lot of what we're going to talk about today is just plain common sense, but what you think is common sense, some of your patients might not see it that way. So some of this stuff is going to be very basic, but again, you got to remember we're trying to educate the patients at the same time about these medicines. Just because they're prescribed, they often think they're safe and not aware of what the problems is. The patient counseling document, this is something you can use. You can print off from your slides to look at to helping counsel the patient. Again, this is a very basic document, but again, it covers some basic things. It can be given to the patient, provided to them or their caregiver at the time of prescribing. It contains important safety information about the drug products that are subject to this REMS. It includes space for you to write additional information in there for your patients if there's something you want to add along with it. It's got a internet address where you can download this document, but basic things about making sure they don't take too much medicine, if they have trouble with breathing or shortness of breath, if a child is taking this medicine, what they should do and what you should talk to the healthcare provider about. So very basic document, but again, it's very handy to have to give out. You can have your nurse go over this with them ahead of time or after you've prescribed the medicine, but it's something very handy. When you're counseling patients about proper use, there's some things you need to make sure. Remember, you talk specifically about the drug that you're giving them, how to take it exactly as prescribed. They're not to take it in any other way exactly other than you've prescribed it. The importance that they stick to the regimen that you've told them about, how they should handle missed doses, and then to contact you should their pain not be controlled or they have other side effects with it. You ask them to read their specific opioid analgesic medication guide that they get from the pharmacist. You emphasize to the patient, the caregiver, they understand that guide, and also stress to them, their caregivers, of course, are reading that guide thoroughly that they get from the pharmacist each time that it's prescribed to them, because sometimes the guidelines do change. That guide gives them important information about the safe prescribing and effective use of these long-acting drugs. And then, of course, tell their doctors about all the medications that they're taking. We reinforce with our patients every time they come in, we want them to bring all their medicines in. We go through their bag of medicines because they're seeing multiple doctors and getting medicines from multiple pharmacies. I'm amazed how many people use more than one pharmacy, so you can't just call one pharmacy. They'll get one drug at one pharmacy and one at the other, even in a small town. So just make sure you have those guides and go through with them. Again, counseling patients about proper use, make them aware of the most common side effects. Particularly some of the side effects, if they're mild, you need to let them know up front. If they're fairly common, so that they'll know to expect those side effects and what they should do about them. Also about the risk of falls, about working with heavy machinery, and also we've mentioned earlier about driving and what they should do in that situation. And of course we've talked about the danger of mixing alcohol with these drugs. And then they call you, their prescriber, for information if they do have any type of side effects. Now, what's a serious adverse reaction or side effect? What should they do? Of course, the most severe, according to FDA's MedWatch, of course, would be death. So they should report if you suspect that the death was an outcome. You should report that was the result of an adverse event and include the date if you know that was done. Other adverse events are life-threatening, and you should report that the patient was at substantial risk of dying at the time of the adverse event, or that the use or continued use of the device or the medical product might have resulted in the death of the patient. If the adverse event resulted in the hospitalization, either initial or prolonged, you need to report that admission to the hospital, that they had an admission to the hospital, or if they had ED visits related to that. And of course, also if they have disability or permanent damage, you need to report the adverse event that resulted in a substantial disruption of the patient's ability to conduct their normal life functions. In other words, they had a significant, persistent, or permanent change, impairment, damage, or disruption in their body's function, structure, physical activities, or their qualities of daily life. If there's a congenital anomaly or birth defect that you suspect was related to the exposure of a medical product prior to conception or during pregnancy, that may have cause an adverse outcome in the child. And also required intervention to prevent permanent impairment or damage. Report if you believe that medical or surgical intervention was necessary to preclude permanent impairment of a body function or prevent permanent damage to a body structure, either situation due to the medical drug or product. And finally, other serious important medical events. Report when the event does not fit the other outcomes, but the event may jeopardize the patient in their situation. So those are just some things to think about as far as adverse events. Things about warning the patient. You've probably heard this about 15 times already, but you can't emphasize it enough. Under no circumstances should these oral, extended-release, long-acting drugs be broken, chewed, or crushed, and patches should not be cut or torn prior to use, because then you lead to the rapid release of the drug, and they're no longer long-acting, they're short-acting drugs. When they cannot swallow a capsule whole, you can refer to the product labeling of those that you can sprinkle, and we'll talk about that a little bit later. Avoid hot tubs, hot baths, and showers, working or exercising high temperatures, all which can cause an increased absorption of a patch product. And then again, remember the use of other CNS depressants, the sedative hypnotics, alcohol, anxiolytics are illegal drugs when you're taking these drugs. And they should only use other CNS depressants, including other opioids, under your instructions, and not under their own or their family members. Also warn patients that they can cause adverse events that can lead to death. Needless to say, that is most of the severe adverse event. You counsel their patients, whether they're caregivers, on the risk factors, signs, and symptoms of overdose and opioid-induced respiratory depression, GI obstruction, allergic reactions, and make sure not to abruptly discontinue or reduce their dosage without talking with you how to safely taper the dose while they're discontinuing. And make sure that you instruct them again to look at their package insert, how it says to take the drug, and make sure that they know to take it exactly how it's prescribed. If the patient displays the following signs of opioid overmedication, they should be instructed to call the prescriber or the poison control hotline. If they have intoxicated behavior such as confusion, slurred speech or stumbling, they feel dizzy or faint, feeling or acting very drowsy or groggy, nodding off to sleep. Of course, that would put most of us in risk in this room, would it not? Unusual snoring, gasping, or snorting during sleep, difficulty waking up from sleep and becoming alert or staying awake. If the patient displayed the following signs of opioid overdose poisoning, the caregiver should then call immediately 911. The person cannot be aroused or awakened or is unable to talk if awakened. They have any trouble with breathing, such as shortness of breath, slow or light breathing, or stopped breathing. They have gurgling noises coming from their mouth or throat. Their body is limp, seems lifeless, and their face is pale and clammy. Their fingernails or lips are blue, and they have slow or unusual heartbeat or a stopped heartbeat. The person who at first only seems to be over-medicated may get worse, so you need to remind the caregivers that they should be kept awake and watched, that they're possibly still absorbing the drug and they might get better rather than worse as time goes on. And of course, if a child or pet ever swallows an opioid that was not prescribed for them, it's always an emergency call for help immediately. Part of this is also about protecting the community. Knowing the poison control number is very helpful when these situations happen. So you should caution patients that they should never, ever, ever share these analgesics with others that can cause them to have severe AEs, including death. They're never to sell or give them away in any circumstances against the law. They're to store these in a very safe and secure place away from children, family members, household visitors, and pets. They always mention pets, so you can tell how we value pets in our society. ER long-acting opioids must be protected from theft, and to dispose of any of these when no longer needed, you've got to read the product-specific disposal information, how you dispose of each of those products, and we'll talk about a little bit more of that a little bit later. This is actually the source of the most recent opioids among past year users. In other words, they went to these users and said, where did you get your drugs? And this is fairly interesting. 54.2% got the pain relievers they most recently used from a friend or relative for free. 54%. 16.6% bought them from a friend or relative, or took them from a friend or relative without asking. 18.1% indicated they got the drugs they most recently used through a prescription from one doctor. 3.9% got pain relievers from a drug dealer or other stranger, and 1.9% got pain relievers from more than one doctor. 0.3% bought them on the internet. So those individuals who indicated they most recently obtained their drugs from a friend or relative for free in the past year, 81.6% of the friends or relatives obtained the drugs from just one doctor. 5.7% of the friends or relatives bought the drugs from another friend or relative, or or took the drugs from another friend or relative without asking. So there's a whole chain of events going on here, as you can tell. 5.5% of the friends or relatives got the pain relievers from another friend or relative for free. 3.1% of the friends or relatives obtained the drugs from more than one doctor. 1.9% reported that the friend or relative bought the drug from a drug dealer or other stranger. Then 0.2% of them bought them on the internet. So it's quite obviously that friends and family are a major source of abused prescription opioid, and the majority of these individuals prescribed these medications got them from just one doctor, but they've been passed from others within the family and among their friends. So that's why we need to educate patients and families, not just the patients themselves, but also the families and caregivers, that these should only be taken by the patient prescribed when given them by their own provider. They take the pill, if they take a pill that's prescribed by somebody else, that's drug abuse. It's illegal and can result in serious harm or death, even if they have the same symptoms as the patient. There are several common misconceptions among family members that contribute to the high rate of prescription medicine abuse. One of these is they don't think because it's a prescription drug, there's no such thing as abuse because it's a legal drug. And if they're legal, they're safer than street drugs. Then mixing opioids with alcohol or other central nervous system depressants, such as the sedative hypnotics, is of course potentially fatal, and patients should be warned against this if you've heard multiple times. Part of this is also educating in addition to educating the family and friends, is also setting good examples for teens. This is a huge issue in our culture right now. The partnership for drugfree.com had a survey of attitudes and behavior among teens in the state of Massachusetts. They found that 45% of parents had talked about pain medications, had taken pain medications without a prescription at some point, and that 14% reported having given their children pain medications without a prescription. The 2010 Partnership Attitude Tracking Survey showed that teens continue to report that their parents do not talk to them about the risk of prescription drugs at the same level as they do other substances of abuse. So you can see from this slide, you can see what the parents have talked with their teens about. While 81% of the teens reported that their parents have discussed beer or alcohol with them, only 77% have discussed marijuana use with them, and only 23% reported that their parents have discussed use of prescription pain relievers without a doctor's prescription. So educate the parents that it shouldn't happen in their house. So there's a 3-step plan for that. The first step is to monitor that. The parents should immediately reduce teen access to prescription medications in their home. They should always be in a position to know if the pills are missing or they're short of pills. They should know how many pills are left in each prescription bottle or pill packet. They should keep track of the refills of their own medication, make sure somebody else in the family is not getting a hold of those and getting the refills. They should follow up if what's going on and making sure that they're aware of the risk and regularly monitor their own medications. Part of that is also making sure that the medicine is secure, that they're locked away, that the prescriptions are locked away as well as the medicines themselves. They should take them out of the medicine cabinet, keep them in a place that's secure that only they know about, and then encourage relatives, especially grandparents and the parents of the teens' family friends, to secure their own medications. And finally, safely disposing of drugs. Safely disposing of expired or used medications will decrease the opportunity for teens and their families to abuse these medications. How often do you have people who have kept these drugs around for years at a time and not disposed or gotten rid of them? They're just sitting there in the home. Let's talk just a minute about drug disposal. There's several different ways you can go about doing this. There's some medicine take-back programs that occasionally occur where a pharmacy or there's a national prescription drug take-back program days that occur sometime where you just come in and bring your medicines back to a pharmacy or drop-off centers and you take them back. So that's one way to do that, but that just happens occasionally. There's also some places that have prescription drug drop boxes located in some local police departments that will accept controlled substances. You need to contact your city or your local government to see if they actually do that. Not all of them accept controlled substances. Now, the federal guidelines for drug disposal are a little bit different, and they've changed over a period of time. A couple of things to remember: it varies somewhat with some of the different drugs, so you need to make sure that the patients do not flush the drugs down the toilet unless the drug information specifically asks them to do that. Okay, so if there's no instructions given on the drug label, there's no local take-back programs available, the drugs should be disposed in the household trash. Now that means you do not just take them in the pill bottle and throw them in the trash. Okay, there's a specific way you should do this. First, you should take them out of their original containers. You should mark off your container so any identifying data is not on there anymore, including how many refills are left. Just mark that through. And then you mix the original medicines in there with an undesirable substance such as coffee grounds or kitty litter, so the medication is less appealing to children and pets, and then unrecognizable to people who may intentionally go through your trash. And I've said this several times, if you look out your front door and people are going through your trash, you might have a problem in your household. So that might be a little clue that somebody might be having a problem there. So they should be placed in a sealable bag, a can or container to prevent the medication from leaking or breaking out of the garbage bag, and then you throw it in the household trash. You just don't toss it in the trash can. Before throwing out a medication, the pill bottle, as I mentioned, mark through it so you get rid of the personal information that's on there. And then, of course, check your local laws. But that's for those medicines that it does specifically tell you what to do. Now, there's some medicines that are a small number of medicines that are so harmful that even in some cases they can be fatal with just one dose if they're used by someone other than the person for whom the medication is prescribed. And this particularly applies to children, pets, or sometimes older people. So there's a few medicines that are specifically said that they should be flushed down the sink or toilet as soon as they are no longer needed and when they cannot be disposed through a medicine take-back program. Flushing these medications down the sink or the toilet immediately removes them from the risk of the home, and these medicines should not be thrown out in the trash. So there should be a medication guide that tells them what they should do with that. These programs are different from different ones, but a lot of these, the biggest one is the ones with adhesive skin patches. Example of that is a fentanyl skin patch. It's been worn for 3 days. Once it's been taken off, there's still enough fentanyl in there to harm or cause death in a child. So those patches should be flushed immediately after they're taken off. You should fold the patch in half so that the adhesive sticks together and then flush it down the toilet. Used or unneeded fentanyl patches should not be placed in the household trash where children or pets can find them. You do not flush the pouch or the protective liner down the toilet. That you can just throw away in the trash can. The same thing for buprenorphine patches. Instruct patients to remove the patch, fold it over on itself, and then flush it down the toilet. The buprenorphine patch can be sealed in what's called a patch disposal unit that's provided, and then it can be disposed of in the trash. But never throw the buprenorphine patch away in the trash without sealing it in the patch disposal unit. Now the question is, does flushing the medicines down the toilet pose a risk to human health and environment? The FDA has been aware of some reports that there have been trace amount of medicines in the water, but the majority of the medicines that's found in the water system are a result of our body's natural means of eliminating the drugs in urine or feces. So far to date, there's been no evidence of harmful effects to human health from medicines in the environment. So there are some of these drugs that are still recommended to be flushed down the toilet. Shortly after the DEA's first take-back event, which actually occurred 2 years ago, Congress passed and President Obama signed the Secure and Responsible Drug Disposal Act of 2010, which actually amended the Controlled Substances Act, allowing the DEA to develop permanent, ongoing, responsible methods for disposal. Prior to this act, there was no real legal means for transferring possession of controlled substance medications from users to other individuals for disposal. So on December 21, 2010, the DEA published in the Federal Register some guidelines expanding the options available to collect controlled substances from ultimate users, and these are the take-back events, the mail-back programs, and collection receptacle locations. However, these regulations are still not permanent, so right now they're still just doing the take-back days. Now we're going to go to a case. This is Ann. She's a 47-year-old female. She has ovarian cancer. Her disease has been stable on the basis of recent imaging. Her pain management regimen has been hydromorphine, ER, 12 milligrams, Q24 hours. It's been stable for over a year. However, for the last 2 months, she's asked for a neuro prescription 5 to 7 days early. Now, you query the PDMP, and you find that she's not been doctor shopping. You get a urine drug sample, which you send to your testing laboratory to be tested using a pain management panel that includes hydromorphone, opioids, and drugs of abuse. When she's questioned, Ann says that she did not realize she was requesting her renewal prescriptions early. She reports no change in her pain control and states that her current regimen is actually still effective. So what are your options for Ann? You can refuse to give her a refill until the correct time. You can make her next prescription for only 2 weeks and have her bring in her pill bottles for a pill count at the next visit. Or you can ask where she keeps her medication and how she secures them. The correct answer is answer 3. And you ask Ann where she keeps her medication and how she secures them. Is someone else getting her medications and she's not aware of that? She reports she keeps her medications in her purse on the top of the refrigerator. After further questioning, it reveals that her niece and nephews have recently been visiting their wonderful Aunt Ann much more often than usual. So what are your options now to do? You could only prescribe 2 medications, 2 weeks of the hydromorphine ER at a time, and request that she bring these back in her pill bottles for pill counts. You can stress to her the safety concerns of the long-acting opioids or taken by someone else when they're not prescribed for them, and request that she bring her prescription bottles for a pill count next time. Or you could call the police. You pick option 2 and explain to Ann that the long-acting opioids are extremely harmful and even fatal with just 1 dose if taken by someone other than the patient, particularly when you don't know whether they're opioid tolerant or not. She is responsible to store medication in a safe and secure place away from her children, her family members, and of course visitors in her home. And if she can't safeguard her medications, you'll have to consider an alternative therapy. You can also not provide early renewal on her prescription again. At the next visit, you review her urine drug testing results. They're positive for hydromorphone and negative for any other drugs that were tested for. She reports that she purchased the medication safe that same day at her last visit. She counts all her medications daily to ensure that none are missing. And she also spoke to her sister about her concerns that her niece and nephews may have abused her prescription opioids. And her sister has also decided to safeguard her prescription medications more safely in her home. So we'll thank you for that.